Here she is. Hi, Carolina. Good morning. Good evening.
Hello. ¿Me escuchan?
You hear me?
Yep.
Yes.
Okay, very good. So Carolina, I was saying to Cristian that we have, of course, in 2 minutes we start, and Josefa, I'll introduce briefly, and then I'll introduce briefly all, and then Josefa starts. We also are running this live, so don't bother about what you see in the chat, because that's only one part of the audience. I'll manage all that for the questions and so on from the various sources. And of course, we'll collect information if we don't cover everything, and we'll send to you if there are follow-ups from the people that you might want to take care of. Does that sound okay?
Okay.
Sí, perfecto.
Okay, good. All right, so 1 minute.
Oye, ¿me escuchan? Que tengo un problema con el micrófono.
Yeah, we can hear you, yeah.
Ah, perfecto. Ya, ok. Hola a todos, perdón el atraso.
Okay, hola.
Cristian, ¿cómo estás?
All right, let's see.
So, Francesco, you will collect the questions and you will distribute them to the panelists,
Yeah.
correct?
Yes,
Great.
I'll be the filter, so I'll pose you the questions, and as they come in, if they come in, I'll give some instructions. Anyway, okay, we go live now. Okay, good. Good morning, everyone, or good evening, depending on where you are in the world. Thank you for joining us here on Zoom and on live on YouTube and LinkedIn. So I would like to introduce myself. I'm Francesco Paolucci. I'm the director of the Value Health Economics and Policy group here at the University of Newcastle, and professor of health economics here and at the University of Bologna. I welcome you all to this session, which is the second session of our new series that discusses the most current debates in healthcare reforms. Last time, for those who couldn't attend, we covered Australia, and of course, for those who are interested, you can join and review the recording of that session on our website. And today we go, we stay in the Southern Hemisphere, and we travel to Chile to discuss more recent and actual, in fact, discussions around healthcare reform. I'm delighted to have today three panelists. Josefa Henriquez, who's actually working at the University of Newcastle as well on health reform, health policy, and health insurance issue. And she was formerly an advisor in the ministry cabinet at the Ministry of Health in Chile, where she focused on related projects to the health insurance reform acts. It is my pleasure to welcome Professor Cristian Baeza, who is the Executive Director of the International Center for Health System Strengthening and the Executive Director of the Center for Healthy Development, former Director of Health Nutrition and Population Practice at the World Bank worldwide, and CEO of National Health Insurance of Chile, FONASA, and also associated with McKinsey and the University of Washington. His very outstanding career in, I would say, advisory and certainly thought leadership in healthcare systems globally. So thank you, Cristian, for making the time to be with us today. Carolina Velasco welcome. I'm very delighted to have you here with us. Carolina has been working on healthcare policy and economic policies more broadly in Chile. She graduated from the London School of Economics and Political Sciences, and really she has become a very active player and thinker in the healthcare policy debate in Chile. She co-authored a number of articles and chapters that look at health insurance and health insurance reforms, but also other aspects of the healthcare system. And she's currently associated with the Institute for Health Policy at San Sebastian University in Chile. She has been the former advisor to the president's cabinet in Chile and a researcher at the Center for Public Studies, SAP, in Chile. So welcome, Carolina, as well. Of course, welcome, Josefa. Last to welcome, though, first to be introduced, because she's very much the starting point of our today's discussion. She prepared, for those less familiar with this Chilean system and some of the ongoing debates, just to kick off a little bit our proceedings. So, Josefa, please take it away.
Thank you, Francesco. Indeed, I will be giving some context on the Chilean system and some of the ongoing issue and the current state. As you will see, there's quite a bit of a debate and also evolving policy scenario. This will not take more than 5-8 minutes, and then we'll get started with the panelists. So the health system in Chile is characterized by two mandatory insurance components in the insurance and financing. And here I have very brief and broad description of how these systems are composed. So the first one, which is the biggest part of the system, is the public insurer, also known as FONASA, which currently insures around 80% of the population roughly, and is financed mainly through taxation and some by mandatory contributions of individuals' income. It's at 7% of their income. Another important characteristic is that people are sorted into different plans, which differ in terms of the requirement of contribution. Some of people, the ones that have no income, don't have to contribute, and some others do have to contribute. And also access to providers. Some of them can use private providers, and some others don't receive subsidies for those services. Just recently, another feature that was included in these plans was that there was some co-payments for some of the groups, but that has very, very recently been removed. So that's why I don't have it in this slide. So services are indeed free at the point of use now for people that use state-owned providers or public providers, and that's true now for all of the groups. The other component is private insurers, and I think an important characteristics in terms of kind of how health systems are organized in a global context is that here, private insurance, in the case of Chile, they are a primary source of coverage. So there is an opt-out of the public system for certain people that can do that, or well, they're all technically able to, but some of them can afford it. They can go private. That insures roughly 15% of the population, and currently the market is composed by 6 open insurers and some that are closed or restricted to certain employment conditions. The system is financed via premiums. Part of the premium is community rated and part of it is risk rated. And the mandatory contribution that is also related to FONASA here goes towards it, but may not be sufficient to pay for this premium. Another interesting feature of the system is that indeed there is no open enrollment, so people can be rejected. This is by regulation, and also health insurers are within certain parameters, allowed to really offer as many plans as they wish. And to date, there's roughly more than 2,000 plans in the system. In terms of the provider market, the market is composed by broadly two types of providers, public or state-owned and private providers. I just highlighted some of the broad characteristics here as well. Primary care providers in Chile act as gatekeepers and are managed by municipalities. There's also hospital and specialty services in publicly owned providers, and then private providers compose the other part of the system and deliver roughly 38% of the total services. And in the figure here, we can see how the insurance component and the provision component interact in terms of how these services are allocated. So most of the people from the private insurers use private providers, but there's also, as I mentioned, some people from the public insurer that can use private providers too. I wanted to contextualize here roughly the position of the country in terms of spending as a share of in health as a share of GDP. And we can see that currently, actually, Chile spends more on average as a percentage of GDP than the OECD countries. So we'll get to that, I think, during the discussion, what challenges that poses to the system. Some of the ongoing issues, this is very broad. I try to summarize some of kind of the broader elements. We'll dive more into them during the discussion of the panel. Roughly in the private insurance sector, structural issues that have been long issues in the system are trying to increase the social role of private insurance and addressing some of the so-called discriminations on age and pre-existing conditions due to risk rating and the no open enrollment feature. Also, some kind of concerns for the people enrolled is financial coverage, high premiums. There's no subsidies in private health insurance in Chile, but also sometimes high out-of-pocket payments. In terms of the public sector, just in broad, in terms of insurance and provision, some of the issues that are constantly in the news and public opinion are increasing waiting lists and waiting times, and also budget efficiency, budget inefficiency, and some issues with the governance. Passing into these are some of the specifics of what's going on right now. So since 2019, where there was a social uprising in the country, this led to a process of rewriting the constitution. The draft of the new constitution to be approved or rejected is subject to a referendum just a few weeks away, the 4th of September. In regards to what this draft of the new constitution says regarding the health system, in broad terms, it would dismantle the current structure, this private insurance and public insurance. There's also some mention to providers, but basically to establish an NHS type system, to be seen, how that will look in practice. In terms of some specifics for the e-Cyprus market that has been in the news lately, so they're being confronted really with a complex financial situation right now. I have just listed some of the underlying reasons, some of the payments due to the medical leave that is also covered by these insurers, and also rulings from the court that prohibit premium increases, added to the regulatory uncertainty. So how to move forward, really to improve also the situation of the public sector. That would be kind of an underlying issue in that area. I just added this last slide to contextualize maybe a bit worldwide, with some countries that have, in some regards, a similar health system, or certain elements of their health system, have elements also of the Chilean healthcare sector. And here I have South Africa, New Zealand, Colombia, Ireland, and Australia. In many of these countries, we can see that their health system is too tired, as currently it is in Chile. And what I would also like to highlight is that many of them currently are discussing, in some regard, kind of restructuring their private systems, or removing them altogether, which is what is going on in Chile. So I thought just to mention that, to get a context of what's happening around the globe. Francesco, on to you.
Thank you, Josefa. I'm trying to see. Beautiful. Okay, great. So thank you for the short introduction. I would like to start a bit the discussions, and maybe Josefa, you can stop sharing at this point. Thank you. And I would like to go to Cristian and Carolina in that order, to start discussing a little bit more in depth and understanding more in depth some of the key ongoing issues, in your opinion, in the Chilean health system and more broadly. Some of the reflection that interests me most, of course, there has been a lot of attention in let's call it judicialization occurring in the private system in recent times. A lot of articles in the press are reflecting, let's call it turmoil, but I'd like your views and understanding of that. And then secondly, given the constitutional referendum, it's coming very soon, that has universal access, which is a very important objective in many countries, certainly in Chile as well. I would like to understand from you a little bit more and discuss some of the changes that this process or the proposal is bringing, and what your initial thoughts are. Cristian.
Thank you very much, Francesco, and I very much appreciate the opportunity to participate in this conversation. You were very involved and know Chile very well, so you might know even more than I know, and I want to begin with that. You probably should be talking more than I do, at least. A few thoughts. Maybe I'd like to sort of make 3 points. One is, Josefa did a great introduction. There are a couple of issues that I think I'd like to add to what she said, and then come to the constitutional discussion and the situation of judicialization. I always have a problem with that word in English. So one is that one peculiarity of the Chilean system is that you have the choice or the opt-out, which is very peculiar for mandatory health insurance. It exists everywhere for voluntary health insurance, but for mandatory in a very few OECD countries. But what makes it even more peculiar is that as no other OECD countries after Obamacare, the private sector participating in mandatory health insurance, the so-called ISAPRES in Chile, the private insurers, are fully entitled to do underwriting, what Josefa called no open enrollment, meaning that they can do underwriting and risk rating, and they have been doing this for 20 years, 25 years. So much so that I would argue that the core business of the private insurance system in Chile is a financial business more than a health risk management system. And that's really at the core of some of the challenges that the ISAPRES are facing for a long, long time, and a spiral with COVID in particular, and with the processes in Chile. The second The second comment I want to make is, I've been invited to comment on the draft proposal of the Constitution for Chile, and I have gone through it a number of times now, and I don't have the impression that the proposals in the new draft are very radically different to other constitutional contents in the world. They talk about an integrated health system, which many constitutions talk about. I thought they would be talking about a single sort of sistema único, as the Brazilians do. The Chilean draft doesn't propose that. It proposes single collecting mechanism for insurance, which doesn't really mean necessarily that it's, FOSIGA in Colombia is a single mechanism, but it has multiple insurers. So it's not FOSIGA anymore, it's ADES. So it seems to me that it's less radical than I thought. I certainly don't think it's proposing an English NHS. It is proposing an NHS, but it's in the sense of an integrated system. And then a couple of comments on the judicialization challenge. Look, I do believe that the Chilean private insurance system, which I really support the innovation of having private sector participating in mandatory insurance, but it has sort of an original sin that has undermined its legitimacy, not only with the population, but also with the judges, which is this underwriting issue and the way the private insurers have really filtered risk and made risk selection the core of their financing model for a long time, and that has really undermined the legitimacy of the system. It's not a technical issue. It's not an access issue. It's, I would say, a perception of fairness more than anything else, and that includes the judges. The median age of a high court judge in Chile is probably 60, and I can tell you that almost none of them have ISAPRE coverage because they cannot afford it, or they have been sort of pre-selected out via pricing and so on and so forth. So there is no love of the ISAPRE system in the courts in Chile, and there is a clash between the concept of the social insurance with double enrollment as FONASA and the concept of underwriting in the private insurance, which the courts have never understood or accepted. And I think he has spiraled in the last 5-7 years. Finally, the comment I will make is I every time I get invited to hear this discussion, people say, there's a lot of uncertainty about, the approval or not approval of the new constitution. I personally believe there is no uncertainty about the future of the health care system in Chile, and that is, I believe that the ISAPRE system is dead. Whether there is an approval of the new constitution or whether there is a rejection of the new constitution. In fact, I think the approval, I'm not advertising for approval or not. I have my own opinion, but I will not express it here. It's just, regardless of what happens, I think the ISAPRE system is broke in the sense that on the sick leave side and on the model of managing risk and managing the contracting with providers have been, is exhausted, and it's just simply financially not viable. So I don't think there is uncertainty. As I was saying, I think that the approval might provide a more sort of stable path to transition. I think the rejection will leave us a little bit of in limbo in terms of what kind of structural changes. But in any event, the situation of the ISAPRE system is such that I don't believe it will survive for more than 12 to 18 months, to be generous, to be honest. So those are my initial comments. I don't know whether those were the initial comments that you wanted to address. Francesco, happy to go deeper into any topic later on.
Very good. Certainly we'll come back to them. Carolina.
Thank you. Thank you also for inviting me. I would say that I agree with most of what Cristian mentioned. The first thing is that, yes, we have a very sui generis system where we kind of combine an NHS, let's say, with this public insurer, and private system, which is trying to go towards a social health insurance system. But as we do not have a coherent system, I would say that they don't work together, and worse, we face the problems of both. Let's say regarding an NHS or a single payer, we face waiting times, increasing waiting times and waiting lists. And regarding, let's say, a private system, we have discrimination and underwriting and all the things that we were discussing. So I think that is one of our main problems. And in that sense, we need a reform. We have been trying to do that for 12, 15 now years, but the political, let's say, debate has, how do you say, we couldn't do it because we are always debating around which is the better system for, or the best system for Chile, which is NHS or system like Germany, social health insurances. And I think that same conversation is now being, debated in the Constitution. I don't see it the same as Cristian indeed in this regard, since I think what the Constitution or proposal for the new Constitution says in relation to this issue, because I would say that for the other, I agree with Cristian that the Constitution is a general right to health care, which is very common with other countries, but there is a special point which was very debated during the discussion for, writing this new proposal, which was whether to include or not private sector, not only in provision of healthcare, also in insurance level. And at the beginning, there was an explicit mention that private insurers would not, manage the social contributions. And then that was erased, but that was the idea. And what it is now in the Constitution, the proposal says that a public organism, we don't know what that means, will manage the money. So I am not sure if that allows what Cristian said. I also want to believe that we can move towards a system like Germany, where private insurers, different from ISAPRES, because we have some problems with them in relation to the regulation, will be able to manage, to administrate this social contributions, which are part of our funding for the health system. So I am not sure that the new this draft of Constitution is really allowing that. And also, well, there was a debate with private providers, but then finally they put the write down in the proposal that private providers will be allowed if they, accomplish some requirements that will be discussed later in some law. So in that regard, I'm not sure that this Constitution, the new one, if approved, would be or not a barrier, for moving towards a system like the German or the Netherlands one, the Dutch one. And regarding the judicialization, I don't know how to pronounce that as well. I think we are now facing a crisis, a new crisis, let's say, because since the last reform was implemented at the middle of the 2000s, people started suing, their ISAPRE, the private insurer, saying that they could not, raise the price of the premium of the plan. And that has been continued, and the system now is almost broken, since the prices were frozen for 2 years during the pandemic. And the solution that was passed in the Congress last year, which was to regulate the increase by the superintendent of health, let's say the government, was now unrecognized. I don't know how to say, but by the let's say the executive power, and also by the judiciary, they say, okay, it's not legal. What we passed last year is not legal. So we are now in a problem that at the end is, we have a saying in Chile, we said le llora, that is, we really need a health reform. That means that at the end, the problem is not that we are suing our private insurers, or we are, the ISAPRES are regulated more or less. It's that the system is not working. We don't want, and the judiciary, as Cristian said, do not want this system. They understand that we need to move to a more, let's say, social insurance model, in the sense that we cannot stay with this private system, not or unregulated system. So in that sense, I agree that the reform is, I mean, we need it now or the next year, and what the Constitution will be doing is just, you know, supporting more one or another model, as I see it.
Thank you, Carolina. So I would like to pick up on this point. Like it's and Cristian and I have had some interactions. It's after COVID, although it's not really after, clearly, but there has been, I would say, pretty much globally, a lot of attention and translated into high degrees of spending towards healthcare. And clearly, many countries are looking at this as something not necessarily problematic from a pure economic perspective, but definitely quite challenging from I would say a fiscal rigor perspective, especially in this economic environment and financial environment, extremely volatile, with a lot of macro challenges, and also structural related to supply chain and so on. Now, obviously, one could just reflect on whether we can do things better. Some countries, and I give you briefly the example of Australia, has benefited so far from the increasing prices in some minerals, and has increased, in fact, one-off increasing spending in some states to up to 10% increase, which is unprecedented. But the Commonwealth, so the central government, is very worried about these trends, or at least I believe it's very worried. And I would like to get your thoughts on whether, in fact, there is a way in which we can do things better, and not only in relation to spending. Obviously, in Chile, the discussion, as you both pointed out, is complex. Both public and private models seem to have a number of challenges and probably structural problems. Is there something that you think we can not necessarily borrow from other countries, but some guiding principles that you think are worth considering, also to perhaps tackle more fundamentally the issue related to spending resources in health in a more efficient way? Cristian.
Thank you, Francesco. Yeah, I mean, the first distinction I would like to make here is that we in the health sector, which tends to be dominated by the healthcare sector, tend to confuse the discussion between health and healthcare. And I think if I were to take one step, really decisive step, is to separate them in the conversation, and make sure, as a first step to do things better, to make sure that we have a conversation about health and not only healthcare. I think as you look at health status of our populations, particularly of high-income countries, as Chile is included there too, it's very clear that the answer is not healthcare, with all due respect. It will be for a while because there is a stock of unmet demand of people who are, have a lot of risk factors like me and all of that. But it is very clear that there is no country in the world that will be able to face what we are facing in health, which is non-communicable diseases, chronic disease, behavioral, healthy behavior issues, and all that, nutrition, all that, through a more even a more efficient healthcare system. So I think that's my first point. I think we really need to have a serious conversation in terms of investing in health, which doesn't mean necessarily the capture by the healthcare industrial complex of the additional resources that we should invest in health. That's my first. I think the second comment is that, for sure, Chile has a lot of things to. The first thing, is that from a technical perspective, the answer to the issue of solidarity and non-underwriting, all that is not a technical answer. If you talk to actuaries, they will be very happy to do risk rating because it's a more efficient system and solve the issues of necessary cross subsidies on the risk side or the income side in a different way, which I tend to agree. I have written about it. Societies don't agree with us. I think all over the world, we have opted to solve these problems in a single instrument, which is a health insurance that has some elements of cross subsidization inside of it. And it is going to be very difficult to, reinvent the social contract on this. And therefore, I think we need to solve the issue of underwriting and really lift that, what in Chile is known as the Carta de Declaración de Salud. I think the last big country to do that was the US with Obamacare when they lifted pre-existences and exclusions. I think there are significant other learnings that we should, look at. I personally believe nobody likes the health insurance, the health system of the United States. I live here and I don't particularly enjoy it. But there are some very important lessons in the sort of post-creation of DRGs and in the late 80s and the transition to healthcare value creation that purchasers and insurers and providers have really moved dramatically, particularly inpatient in the United States. And I will look at it together with what the Germans have done. I also think that, and Carolina mentioned this, on the insurance side, the experience of Colombia, the Netherlands, and Germany, vis-a-vis, in contrast to what the National Health Service in the UK is going through. I have the privilege to work with friends and people of the NHS, the English NHS, not the others. And they're going through pretty tough times in terms of the incentive frameworks of that kind of design. So I think those lessons are very important. I would like to, refer back, and with this, I finish my comment, Francesco. I don't live in Chile, although my heart is in Chile all the time. It seems to me that it has been difficult for the constitutional discussion in Chile to separate sort of the constructions, the fantasies, whatever, the interpretations of the text, the constitutional text, and the text itself. I think that when you read this text with an international eyes, looking at many systems around the world, is not so clear for me that there is only one single solution to the issue. I thought they were, as Carolina said, the initial discussions were like a single solution, like almost a Szymanski kind of system, not even an NHS. but it ended up to be pretty general with some pretty big opening. So I'm less convinced that there is a single solution space here. And I think, given the conformation of the Congress today in Chile, which is very different as compared to what the conformation of the Constitutional Assembly, I am not so sure that the intent in the minds of many constitutional members is going to be actually embodied in the new legislation. So that's why. So those are my comments, Francesco.
Thank you. Excellent. Carolina.
Thank you. Yes, I was thinking on what is our, let's say, structural problem in relation of the use of the resources, because as Josefa showed in the slides, we are now, spending a lot of money, more than the average of the more developed countries, and there is a point where we need to make a better use of them. And in that sense, some other reforms are also being or have been discussed, and they have been now out of the discussion, and I think we have to go back to them. For example, the first one, we have now that all or the majority, all the hospitals, the public ones, depend on the Ministry of Health. But the Ministry of Health is also, the institution that rules the sector, that is in charge of evaluating, of monitoring, and incentivizing better outcomes in health. So now the ministry is really in a problem, because they have to evaluate itself in the sense of saying, okay, my hospitals are with huge debts. They have this problem of waiting times. So they are not really in a good position to evaluate them and to, to demand more from them. So in that sense, I think we really and urgently, even if we move to a system like the English one or to another system, and most if we won't go to a single payer system, we need that the ministry, or maybe put it in the other way, we need that the providers, the public providers, go independent from the ministry. Cristian has had worked in this area. You know what the the WHO and other World Bank has been trying to do in some countries, which is to separate the functions in health, the ruling one, insurance one, or the managing of the resources, and then provision. And in Chile we have them sort of unified, which is very problematic for what you were also saying before, which is health, because all the efforts, all the money, all the system capacities are put on healthcare, on hospitals, on waiting times, but the ministry is not doing prevention. Public health, which we have two undersecretaries, the one in charge of the provision providers, and the other one is called a public health undersecretary. But that undersecretary manage a little, of the resources that are for health in Chile. So if we say, okay, what is going on there? Well, all the money, all the efforts are putting, down on hospitals, on health care. But nothing or very little in prevention. And the pandemic was very important for us to see this. The risk factors in Chile were very high: obesity and smoking, all the other factors that were important for the pandemic in Chile were very high, and we are not tackling them. And in that sense, I think any reform will need really to improve the way we manage our resources. That means to separate provision from the ruling institution, which is the Ministry of Health. And also we need to reform the way the public and the private sector, if the private insurer sector, subsists in the future, we need to improve the way they manage our resources. That's for sure. We know that the public sector do not make a good use, for example, of, let's say, the hospitals, because they are used only in the morning, but not in the afternoon. But we are paying for the whole day, to our human resources. Why are we not making a good use of our bargaining power, let's say, because the ministry, sorry, FONASA, the public insurer, is buying, a lot of, well, now we are doing a better use, but let's say 2 years ago, we were using payment methods that were very obsolete and that were not, improving or incentivizing efficiency. So I think there are those things that we need to improve urgently, even if we move to any of the two options or more for reforming, the way we administer our resources. And I think that in that sense, you also mentioned before access or universal access. I think in that regard, we also have, stated some basis. We have this minimum benefit package, let's say. It is called HES, where people can have free or almost free, with a very little copayment and timely access to the attention, the care for, at this time, 85 healthcare conditions, problems of health. And that has worked very well and has worked with the rules of, let's say, social security or social insurance system, in the sense that there is a lot of solidarity. So I think as we already have that base, we need to, to build on that, on what we have. That is why I'm worried, Cristian, because I know maybe if we interpret the Constitution, the new text, as something that really allows different models, what the government wants to do is to go towards a system like the NHS, but like next year. They want to how do you say, introduce the reform now in November, and then to pass it in 1 or 2 years, and then we are all going to the single payer, which I think is very dangerous, because the transition for a model like that needs all what I was saying before, to transform and to reform our health providers, public health providers, to make a better use of our, powers as a single insurer, and many others reforms. The ministry also, I would like to have some kind of HTA, institution, or to enforce the one that we have, which is doing health technology assessment, but in a very, let's say, initial way. We need to improve, professionalize that more. We need to do many things before we move to a system which would be in the hands of only one, state operator, let's say. So I'm worried about that. I think we need to do these other reforms before. And then we have to have we need to have this conversation to see, okay, where we want to move, considering what we have now. Thank you.
Okay, thank you. This is very interesting indeed. I thank you both. So now, when I hear this debate, it's fascinating. Sometimes the temptation is going back, to the sort of whiteboard and start from scratch, because fundamentally the issue here is health and associated risks, and in fact is pricing that risk, and that requires then articulating a system, I would say, of financing and provision. So when I say this, going to the whiteboard, obviously I also have my mind going to the current constitutional debate, which certainly brings in new lymph and possibly change that only Chileans really can can judge or evaluate whether for healthcare and other areas is well well expressed and outlined in the current proposal. Now, asking this in another way, is the current constitution, Carolina, sorry, is the current constitution a barrier for the changes that you are thinking about? And then we have 12 minutes, so I ask you both to be brief, because I would like to also ask you some questions that I'm getting from the audience. So is it the current constitution a barrier for the changes that you were discussing before, Carolina?
Thank you. I was thinking Cristina is like the mix of Cristian and Carolina, so no worries. I think to some point it is, because I support more a reform that goes like the German model or the Dutch model. So I think that our current constitution, which states that each person has the right to choose between the private and the public system, could be a problem, because if we think that we want a single system, I think we agree on that, Cristian, that we needed to integrate the sectors now and to have a single system, that can be done in different ways. But in that sense, and as the constitution, does not really define what system means, it could be interpreted as I have the right to choose, what to do with my contributions, with this now 7% of the salary that goes to fund private insurers or public insurers. So in that sense, it could be a barrier. If you said, okay, court interpreted like the private system is the swapper system or some, I don't know, complementary private insurance system, maybe then it could be a problem. If we want to move to a, let's call it public integrated system, but that allows, the money to be administered by private insurers, like the German. So I think it could be, but it has not been a problem or a barrier until now, and we have been doing some reforms on that direction. But I'm not sure if we do the big reform and we go like the Germans, that could be a problem. Yeah.
Okay, thank you, Carolina. Cristian.
Thank you, Francesco. Briefly, I think the current constitution is a big problem for many sectors. There are issues on, mining and, natural resources, the political system, the hyper power of the Ministry of Finance in Chile, and so on and so forth. I think for the health sector, I tend to believe it's less. I think some of the biggest issues, such as, for example, the private insurers being entitled to do reselection and all that, it's not even a law. It's an interpretation of the law by the regulator many years ago. And so I believe that some of the big issues are less of an issue with the Constitution. I also think the current Constitution, however, have certain rights that I adhere to that will not happen. So some of the changes proposed by the new Constitution on reproductive health, the legalization on abortion, and the assisted suicide, which are illegal in Chile today, and it would be legal under the new Constitution. And there are other protections on disabilities. But I think the current Constitution, in my view, is less of a problem than ourselves. As Carolina said, it is us. The impossible capacity, of the Chileans to actually overcome their history and agree on a reform of the health system, which is a proxy to the battles that sort of the left and the right have had historically in Chile for the last 30 years. And unfortunately, that is played in this field too. So I don't think the current constitution is the biggest problem. There are some issues, but much less than I would think.
Okay, thank you. Now, Gabriela Uribe, I think from the University of Sydney, has asked a few questions here. How prepared, I suppose, is the Chilean health and social system to implement the new policies? I imagine, in a broad sense, novelty, and how do these new policies, in fact, take into account what seems to be an increasing trend of migrant refugees that are currently not covered by any system, and also how can health and social care be better integrated? Cristian, please.
Do you hear me?
Yes.
I think. I hope. Yeah. Okay. So I don't think that the Chilean system is prepared. So first of all, I don't think it's clear what the new constitution is putting on the table. And I think Carolina and I sort of agree, although I think she has a stronger view of what is implied. The new constitution is relatively fuzzy on specifics. And I think the Congress will basically decide, and the conformation of the Congress will be different in the new constitution. So therefore, it make a difference. But I don't think so. The straight answer is I don't think Chile is prepared under a new constitution for which we don't know the specifics of what the legal framework would be, or even under the current constitution, to face some of the challenges that she's raising. I think the migration challenge for Chile is, I am a migrant in the United States, so I completely understand the challenges, although I'm a privileged migrant, but it's a different issue. I think Chile has two big challenges I have not been able to tackle. First is the First Nations issue and the sort of the diversity and unity that is required for the Chileans moving forward. I think there's a big conundrum there, and the current constitution certainly doesn't provide a solution to that, and the new constitution probably doesn't, because of it went to the other side of the equation. I think the second challenge is migration, which is a nice problem to have. It's fantastic that so many Latin Americans have chosen to go to Chile, except that Chile is not prepared to actually provide the basic services and integrate them to the Chilean state. So I think the next 3 years, whatever happens with the approval of the constitution, will be a big challenge for the Chileans in the sort of the huge legislative reforms that need to be done for the new constitution or for the old constitution to adapt the health sector and other sectors to the new times. Back to you, Francesco.
Thank you, Cristian. Carolina.
Thank you. Yes, I agree that it depends on how we make new laws, in the sense that the health reform will occur even if we approve or not the new proposal, and if we don't, we will have a new one in any case, because we will start another process for a new constitution. So that would happen at some point, and we need these reforms as we were discussing at the beginning. We have a crisis now. And in terms of the refugees or migrant problems or situation, in relation to health, they are covered by FONASA, the public insurer. So I think we could improve that, and we can do it with the current laws. It is not on that sense, but of course, if we have a universal system, all the people would be covered only for being in Chile. Well, that depends also on what the law says, but probably that would ease, you know, the incorporation of people, not only migrants but also other people who that is not working or in other situations. What I think is the most important challenge, I think, is the relation between the social care and also health care, because we have been treating them like different systems and different subjects, and they, of course, and it is more easy to see the way they connect when people age. They are more connected, you know, at that time, and I think we have to do something there, because we do not have a good system for you know, for people over 60 and 65 when they, for example, dependents, when they are not able to work, or people that are not able to I don't know, do their personal things, such as going to the supermarket, going to the doctor, or whatever. We need a better long-term care system, which also includes social care. I think in that sense, we have a huge challenge. We are also having this discussion on pensions here in Chile, which is also related to old age. So I think we have to think that better in an integrated way, and I think this is a good moment to do the, because we don't have nothing, or what we have is a little. It's not that we have nothing, but in opposition to health, that we already have a let's say, strong system, not the one we want. It is not perfect, but we have a strong system. If we think on what we have for social care, old people, and health for old people, I think we can, you know, design it in a better way, not from scratch, but almost. So I think we have a great opportunity there.
Thank you, Carolina. Well, I'm receiving a lot of messages from the live. We have come to the end of this session. I mean, there is one that is very cheeky from Anonymous that says, "Thank you for the wonderful conversation. What should I do? Yes or no?" And I always like I selected this to conclude, because I of course wish you the best wisdom. I'm not gonna ask that to our two great panelists and to our presenter, Josefa. Obviously, you know, many other countries are voting at this time. It's always difficult to come to that decision. All that we can say, I think, in agreement with everybody, is certainly to vote. That's important. But on that really funny note, thanking all the questions coming in, I'll go through them and propose them. And for those that have revealed their identity, I'll seek to respond. Thank you, Carolina, for being with us today. Very precious, your contribution. Thank you, Cristian. Delighted and appreciative of your continuous support and contribution to today's proceedings. And thank you, Josefa. In saying goodbye to you, I say goodbye to all that have been participating and being so active as well. I invite you to follow us continuously on Twitter, LinkedIn, and our newsletter. Obviously, will come back soon with the next discussions on the debate on healthcare reforms, certainly tackling and bringing in more countries and more questions that seem to be increasingly similar and urgent in many countries. Thank you, everybody. Have a good day and a good night.
Thank you very much for the invitation. Take care.
Thank you very much.
Bye.
Bye.
Good to see you, Carolina.
Igualmente. Que estés bien.